Hey everybody, today I'm with my very good friend Haneen, who is a physician assistant who works with me in critical care. She is my colleague. She also has had a career in trauma, worked for a trauma surgery team. So today we're going to be talking a little bit about her background, a little bit about trauma, how she transitioned to critical care, and a lot about what the difference is between physician assistants and NPs. This is a request I've gotten from a lot of y'all. I think maybe you'll be surprised, maybe you won't be surprised. Maybe we'll get into a little bit of her personal stuff too. She is married to a resident, which I find is very interesting because she lives a very busy and full life. So if you're interested in any of those kind of things, please stick around. If we haven't met, my name is Bree. I'm an RN, NP mentor, interview strategist, and content creator. Welcome to the channel. Okay, so I guess I wanted to just start by having Haneen tell you all a little bit about her background, how she kind of first got the itch to go into healthcare.
So when I was younger, we had a lot of exposure early on to underprivileged areas overseas and in the US. And it was then that I noticed the difference between different health disparities throughout the world and as well as in America. And I found it really fascinating and was studying and reading a lot about it, trying to figure out what we can do to fix those huge gaps in healthcare. So I initially went into pre-med. My family background is a lot of them immigrated overseas from Palestine, 1 to 2 generations ago, depending on which side of the family we're looking at. And a lot of them were in medicine or lawyers or teachers, different things. So I had exposure to medicine
Sure. So
prior
it's kind of
to.
in your blood already.
Yeah. So I initially was doing pre-med, and then I took a really hard chemistry class and thought this wasn't for me.
Oh, dude. So you and I had the same experience because I was pre-med also until I got to organic chemistry. I was making a C, and I remember the teacher like speaking Greek, and I was like, what? I don't think I cut out to be a doctor. This is what it's about.
So I took a break from that for a couple of semesters, did social work. I was good at social work, but I felt like it wasn't giving me everything I was looking for in terms of the type of work I wanted to do with people. So then I happened to fall into PA school and started researching that, and I thought it was a really good middle ground between med school and social work, and still trying to have a balance with my family in the future and being able to change different areas of medicine if I wanted to later on. I knew that one of my fears was if I did med school and couldn't match in ER, for example, I ended up doing something different, I was going to be a little bit bitter for the rest of my life not getting it. So I did physician assistant, knowing that it's a general area of medicine and I can just switch to different things, which has worked out pretty well for me.
Yeah. Did you ever consider going to NP school or the nursing route?
So I did initially, but I was almost done with my bachelor's by then. So I ended up just applying straight to PA school because I actually was debating between PA and CRNA school. I intentionally didn't do NP school because I was worried about being stuck in a specific area of medicine, similar to med school itself. That was a really big fear of mine.
That was your I can totally see that, and that was going to be one of the things I was going to ask you about later. And something that is a little bit different in how we practice is that your training and my training, we practice very similarly, but our training is very, very different. You know, as an NP, you really got to, the reason you're able to bypass medical school and condense all those clinical hours is because the presumption is that you've already been working at the bedside. So, and you're really, really narrowing down the focus of what you're doing versus in medicine or PA school, where you have a lot of rotations in a lot of areas. So you have more lateral mobility than NPs do. So that is one benefit to your type of program.
Yeah.
Do you, I know some PAs and I know some PAs on social media, and from what I hear, it is very hard, very competitive to get into those schools. So do you find that to be the case?
Yeah, I think it is, because there's people that are applying with 4.0 GPAs. They do a lot of extracurricular activities. They have what you would call a perfect application, but for whatever reason, they don't end up getting a spot. And a lot of that, I think, crosses over to how personable you are and how good you are at the interviewing process. It's pretty rigorous. And the reason it's so competitive is because there's not enough PA schools yet. I think with time, as they open up more, maybe it'll get better. But I remember my program, we had 20 spots and 1,000 applicants. So
wow,
it was a lot.
I didn't realize it was that much.
It was a lot.
Wow.
Yeah, it was a lot. I don't know how I got in until now. I'm like, it's just luck.
Yeah.
But I think a lot of it, the first part of getting an actual interview itself is a numbers game. You have to rank for example, first top 100 to qualify for an interview, and then after that, they narrow it down from 100 to 20 or 40, however many spots the program has. And that is really when it comes into play of how much of a people person you are,
Sure.
how well you are at reading cues. And I think that does a good job because bedside manner, as you know, is so important.
Sure.
And even when you get your first job, which I'm sure we'll touch on later on, how well you're going to do in your job is not only how smart you are, but a huge part of it is how likable and how um, well you can get along with different types of colleagues and different types of personalities.
Sure.
Yeah.
Just like interviewing for a job, it's about the fit and how they
Yeah.
think you're going to represent the profession as much
Yeah.
as anything else.
Absolutely.
Sure.
Yeah.
So your program is 3 years long?
2 years.
2
There's
years. Okay.
some that are 3. They're meant to be prolonged a little for people who can't go full time right away.
Mm-hmm. And I feel like I've read that you guys have like 3,000 to 6,000 hour clinical hours you have to complete while you're in your program.
Yeah. So the way the program is set up is it's 24 months. The first 12 months essentially are didactics. So you go over, you have pharmacology, clinical medicine, pathophysiology, patient assessment, and other ones I can't think of right now. And every semester, different programs are structured differently, but you essentially go through every system head to toe, and you go through the clinical medicine of it, the pathophysiology of the heart, for example, and then you learn about the medications, learn about the physical exam assessments, and whatever procedures you can learn in that process too. And then the second year is all rotations, which I think is one of the differences from NP school is the entire second year you have your core rotations similar to what the med students have.
Sure.
And then you have electives like they get to choose as well. So when we started doing our rotations the second year, they told us we have to be comparable to a third year med student in knowledge and capabilities.
Yeah.
So.
And I think, did you have a cadaver lab in your program?
We did.
So these are some of the differences that I hear from a lot of people between NP school and PA school. It's more science based. It's definitely very highly modeled after medical school. So I went to an Ivy League NP school and I didn't get a cadaver lab. But the presumption is also that unless you are specifically training in an OR field, you're not going to probably be going into an OR. So most places that I know of preferentially, that's the word, preferentially hire PAs because they've had OR rotations. Was that an elective for you or required?
No,
rotation?
you have to do surgery, and that time you'll get OR. Yeah.
Okay. Yeah. So most RN or most NPs who work for a surgical team in an OR are also RNFA, which is its own separate certification because we don't get that routinely. We don't have that cadaver lab, that intense anatomy stuff. We don't get a lot of that. So that's some of how our practices, well, not really how our practice, but that's some of how our utilization differs a little bit. Okay, so let's move on to, your first job was working for a trauma team, correct?
I was a hospitalist.
You were a hospitalist. Oh, I don't think I realized that. Okay, so tell me about that. How'd you come into that job?
So I came into that job when I was actually towards the end of rotations. I had done a internal medicine inpatient rotation towards the end, and they were hiring for a nocturnal hospitalist APP at that time, and I had interviewed. And when you graduate, you kind of get this sense of urgency to hurry up and get a job, and you just take that job.
Yeah.
And my initial hope was to go on the ER track when I first graduated, but I was in a rush to sign, and you get a little panicked, so I signed with that job. And now looking back, I'm glad I did because it gave me a really good foundation in the beginning. It was a really high volume, high paced hospitalist position. So I did that for 3 years. And then while I was doing that, I picked up a PRN or contingent urgent care job to keep up on the ER skills that I had wanted to eventually transition over to.
Okay.
And I had tried to apply to ER jobs a couple of times, but I was a little bit picky about which ones I wanted. And at that time, they had done a huge hire of a lot of APPs, so they didn't have any positions open for a couple of years.
I see.
So then I came across trauma, and they had a position open. And I thought, okay, let me try trauma. It's similar to ER. I can get the exposure that I need to and eventually jump back to the ER. And after about 3 years of hospitalist, or maybe 2.5 years, I did trauma full time, and I loved it.
Yeah. And how long did you do that for?
I did that for 2 years, and then I moved to Georgia.
Yeah. From what I see locally here in Georgia, I do have some PA colleagues for sure, but I have far more NP colleagues that I see in critical care roles. And I think it's just because so many of us are nurses that worked in these units and
Yeah.
went back to school and developed relationships.
Yeah.
Did you find it? I mean, I know your situation was a little bit hard, but did you find it necessarily hard to kind of branch into ICU because of that?
No, I don't think so. So the team that I was hired in with intentionally hired a mix of NPs and PAs. And I think really any team, whether it's a hospitalist, critical care, whatever you're doing, needs a mix of both because they
Agreed.
bring two different
Yeah,
things
agreed.
to the table. So
Mm-hmm.
I felt like because it was a mix of PAs and NPs, I had a really strong medical background, but they had a really strong bedside, day to day communication issues, and then as well as experience that just helped us flow really, really well as a team.
Right.
Because there was something that maybe I knew because I had learned about it and read it, but then trying to maybe apply that exact situation into a real world scenario, the NPs, because they had been really good nurses for a while beforehand, before transitioning to NP school, could kind of help me fill the gap and try and translate it into
The reality.
yeah.
Yeah, that's kind of what I find too. I mean, obviously I've never trained PAs. I've trained a lot of NPs, but a lot of bedside nurses bring with them the like pattern recognition thing. Like, I know
Yeah.
something's wrong,
Yeah.
but I may not be able to actually verbalize it, but I can tell you something's wrong
Mm-hmm.
because they've seen it a lot.
Mm-hmm.
And or just the little things like, why is my patient's sugar not going down? Well, because
Yeah.
they're giving actual nursing doses and not the reality. Well, you wouldn't know that unless
Yeah.
you had worked at the
Yeah,
bedside kind of a
exactly.
thing,
No,
So some of
exactly.
those little behind the scenes, but where we lack in cadaver labs and some of the more science backing of our education and some of the surgical skills, they will also bring to the table. So I agree, it's a very good mix.
Yeah.
I will say across the boards, though, people ask me a lot about whether they should go the NP or the PA route in regards to concern about how they'll be able to practice. And I will tell you, we practice the same
Yeah.
way.
Yeah.
When I meet people, all types of APPs in the hospital, half the time I cannot remember if they're an NP or a PA
Yeah.
because
Yeah.
we practice pretty much the exact
Yeah.
same way.
Yeah.
I feel like unless you're planning to go into a surgical specialty in the OR, or you want to open your own practice, which is a difference on our side that
Yeah.
NPs have, is that we can practice autonomously. So if
Yeah.
you're in an independent state, you could open your own practice. And
Yep.
if you're not an independent state, you can with a collaborator. There's a lot of caveats there, but the potential is there.
Yeah.
Versus I don't think you can practice independent. So
Mm-mm.
you have to have a collaborating physician
Yeah.
pretty much anywhere you go.
Yeah.
So it depends on what your goals are in life, and where you're at. And she was at the right place, like pretty much done, just needed to go straight into it. I always advise people, if you're a nurse and you're interested in becoming an APP, probably just go to NP school. You can do it in an abbreviated time frame.
Yep.
So it's just a matter of what's right for you at that point
Mm-hmm.
in life and what your goals are.
And I did have in my program, I want to say at least 6 or 7 of the students we had were nurses previously.
Interesting.
So they had a huge advantage over me of even learning just the medical language. I remember taking an exam and I saw the word ambulate and I didn't know what that meant. Yeah. And where the nurses coming in knew that information, or the paramedics or whatever exposure they had beforehand. Yeah. I was a medical assistant, so it was a little bit less limited familiar. Yeah.
Sure.
But they did great. And a lot of them told me they picked it PA over NP because of the autonomy they noticed. Michigan, before the NP school started really expanding, a lot of the surgical specialties or inpatients tended to be heavier on the PA side than they were the NP side. I think it's pretty much balanced out now, honestly. Yeah. But you just have the freedom of changing your specialty at any moment if you needed to, right, as a PA. So I think a lot of people needed that.
You have a more lateral mobility. Yeah. I also would argue that, NP schools are not regulated well like PA schools are. And I think because PA schools are modeled off of the medical model, physicians sometimes tend to prefer PAs because they're trained similar to how they're trained. Now, the inverse could be true as well. Yeah. So it's going to vary. But in general, I feel like the reputation for PAs has been upheld far better than it has been for NPs, because we have so many programs popping up that are kind of doing sort of a subpar job in educating people, which y'all already know about all my soapboxes, so we won't go into that. But these are some of the gives and takes of what program you choose. Tell me a little bit about your trauma job. What was that like?
It was a strict APP run department, so that was nice because any patient that came in, the APPs took care of. They did all the procedures for them. They did anytime they went to the OR, we took them to the OR. So that was nice. So
you rotated through surgery as well. Okay, so you were involved in the care of the patient from the time they roll in the door, resuscitation in the
Yes.
ER to OR to really, so you get full spectrum
Yeah.
view of what is very
Yeah.
interesting. Okay, that's
So I was
cool.
very appreciative of it because I felt like it really, as a provider, just makes you much more well-rounded if you know how to manage a patient from, like you said, the
Sure,
moment in
start to
the
finish.
ER to the ICU to
Hmm.
discharge, everything. It just
Hmm.
kind of, it's a lot to learn in the beginning, especially if when we hired new grads, I felt like it was a lot to take in. Even if
Mm.
they were nurses and amazing nurses, it's still, being a nurse is so much different than being a provider.
Yeah.
You're,
Oh, complete
so it's,
180.
it's a
Hmm.
big jump, but everybody did really well. So um, I think overall, I was lucky to have that job.
Sure, sure. So then you moved to Georgia, you took the critical care job. Tell me about that transition. How was that for you going from the surgical ICU to the critical care, medical care ICU?
So one thing, if you guys are interested in NP or PA school or nursing school, anything really in the medical field, is you have to learn how to look up information that you don't maybe know the answer to, and then you can work your way through things, because even if you aren't familiar with something, at least you know how to find the
Yep.
answer or who to refer to if you need help.
Hmm.
Um, I had been the hospitalist PA for a while, which crosses over really to any area of medicine, I feel like, pretty well. And then I had been doing trauma for so long, I hadn't been in a position where I was unsure more often than not until
Hmm.
I came to Georgia. And part of it was when I started, it was the COVID wave and there
Oh
was
yeah.
just patients everywhere.
Yeah, poor Haneen. I will tell you, she got it worse than anybody because she rolled in the door. I think it was in Delta. Was it
Yeah,
summer?
it was
Yeah,
Delta.
so the worst wave of all. We're in a COVID hotspot, and we were like, "Hey, here's 10 patients. Good luck. If you need anything, call me." I don't know. Like it was. We were all just,
It was a
drowning.
lot.
We were
It was a
drowning.
lot, but if you guys can get your first job to be something that, I don't want to say is high stress, but something that is fast paced, I think your first job really sets the tone for your entire career. My
Mm,
first job was a job where it was nights. People weren't in house, they weren't available to answer questions. You were doing 10 admissions a night. I think the
mm,
average amount of admissions I would say a night for one person to do is maybe 5 or 6. So we
yeah,
were doing a lot more.
yeah.
And it was stressful the first couple of months, but after that, um, it just forced me to become so much more efficient. And even when I'm training new grads now, one of the things I reiterate with them, which everybody does, I know you have too, is you need to be efficient. You need to learn how to become as efficient as possible, or everything will slow you down and be overwhelmed
Mm,
all the time. So I felt like when I took the job in critical care, it reminded me of that. Was okay, now I just have to remember how to become efficient. How do I assess the patient? How do I do this? How do I do that?
yeah,
I remember even trying to get from one floor to another was something that I was just so stressed about because it was so
it is
confusing.
confusing where we work.
But after a couple months, you get the
Yeah.
hang of things again, and you know your colleagues well enough by then that you start to be able to trust them more, and you know that they're there for you when you need things, and it just makes things so much smoother.
Yeah. And I also think like because you've had so many different specialties that you've been in, once you've done one and you've realized how bad it is, and you get past that imposter syndrome of
Yeah.
why I should not be responsible for another human being's life. Why are they putting me in this?
Yeah.
So you're not really there, but you are in a place of okay, now I've shifted 180 and I'm focusing on something totally different. But you know how to learn where to go and that it's going to eventually get better. So it's
Yeah.
not quite as
Yeah.
overwhelming. But I have talked to a lot of people who have switched specialties, and many of them have said it is just like starting over
Yeah.
because especially some of these really really super niched areas. If you've been so, what do you like and dislike about critical care?
Um, what I like about critical care is how challenging it is. So I did SICU, surgical ICU, and medical ICU, and I will say medical ICU is a lot harder
Oh, for sure.
than
Hmm.
surgical ICU. It's so easy. The turnover, I don't want to say easy. Every once in a while, you get your neuro trauma patients that are there for a while, or you get patients who are in multi-organ failure because of car accidents or uh, gunshot wounds or whatever happened to them. Any kind of blunt force injuries that keep them there for a while. Maybe you'll get some surgical complications, but you can usually correct what's happening and
Hmm.
get them out. Where medical ICU patients is just so much more complex. You're in charge of all the organs in a different way because these people come in with these chronic conditions or these chronically failing organs, but you're still trying to correct them and fix it so that they can get discharged and live another day. Where in the surgical ICU, it's either going to recover or it's not most of the time. So it's a little bit different.
Sure.
So for that, I will say, um, I've loved it because it's like you said, I felt like I'm starting over, and there was a lot of surgical ICU training that I had that I felt like I had to unlearn for the medical side. And I actually think that it would make me a better SICU provider in the future to be able to have this medical ICU experience.
Sure.
Um,
Well, I feel like if you can manage, I mean, you're right. There are some surgical patients that they're there for a while. They end up going through multi-system organ failure. So you got to be able to manage all of that.
yeah.
But it's not the majority of them. Whereas I feel like in a medical ICU, like that's everybody, and they come in old, they come in infirm, they come in with multiple diseases, and you're like, all right, how is this the problem or is that the problem? It's just more layers of complexity from the get go,
It is.
and then they can linger forever.
Yes.
So then they develop other problems.
Yes. Yeah. So I definitely cherish my experience here, and then I'm lucky in the ICU that I work in right now because we have quite a bit of autonomy. I would say more autonomy than I've ever experienced with any of my other jobs, and that's even from coming from a trauma job that had no residents. I mean, you still have a lot of exposure, but there's different teams for different things. Like in trauma, I'm in charge of essentially the neck down. So if someone has to be intubated, it's anesthesia that does it. Where in ICU with you guys, head to toe, we cover everything. Yes, if you need to go to surgery or things like that, it's out of our scope and somebody else goes and does it. But there's a huge part of it that we can pretty much handle day in and day out, I feel like.
Yeah.
So I appreciate that part of it.
So what has been the favorite that you have done job wise?
I want to say, honestly, if I can find a job that's half medical ICU and half SICU trauma, I think that would be my ideal job because it keep me pretty well rounded. But now looking back, I really don't think anybody could be a really good ICU provider if you haven't worked in or at least had exposure to multiple ICUs because there's never going to be we're never taking care of, I don't want to say never, but there are times where it's never just a standard MICU patient. It's a MICU patient with a little bit of neuro or a little bit of surgery, and you still have to know how to handle all of those things. So I think
you're looking for a mixed ICU.
I'm looking for a mixed ICU, which is hard. It's hard to come across.
It is hard to come across. Hi, Omar. Haneen is a new mom. She has a 6-month-old baby. Speaking of, we'll segue into that a little bit. She is married to a family medicine resident who is about ready to graduate. Congratulations.
Thank you.
I have watched her kind of go through the challenges of starting a new family in a state without a lot of family support and a husband who is in residency. Could I say more? Any tips for people who might be in that situation? I know there are a lot of people who are married to physicians and physician trainees, and it's challenging.
It's hard. I would say be patient. I have an advantage in that I work in medicine, so I see his side of things in real time, so it helps recenter me if I'm having a bad day or if I'm stressed out, but it doesn't mean there aren't rotations that he's in. I was just telling Bree that next month I've been waiting all year to get over the next month because I know it's going to be a harder rotation for him.
Omar just wants to be a part of this show, and he's being so sweet.
My husband does a really good job. I think so. My sister lives here with my brother-in-law, but she travels for work, and then he's also a resident too. So they're relatively busy. But I think it worked in my husband and I's favor in that it's forced us to find a balance between the two of us of co-parenting with each other. And I know everybody says, oh, everybody has to be 50-50. The husband and the wife are supposed to do equal parts, but it just doesn't work out that way.
No.
It's whoever's available that month. Sometimes it's him, sometimes it's me. Sometimes for 3 months it's only me. And it's just, you have to just adapt and adjust and just be patient.
I've talked to my girls about this too, and I love that you bring that up because I've heard people say that too. It's 50-50 give and take in a relationship. Well, it's not really. Sometimes it's 70-30 and sometimes it's 60-40. And as long as you both are on the same page about who's doing what and what you're both willing to accept, then you'll get through it. And honestly, the hardships can make you a little bit stronger. Starting a whole new family, without the extended family to help is a real challenge. You guys have done it just beautifully.
And I think that's when your job comes into play. I had to drop to contingent because of issues with babysitting, trying to find that. So that was one area I had to sacrifice in. But um, I, in a realistic world, I think it would have been better if I would have just stopped working at all. But mentally, it was never something I would be able to do. I
Sure.
couldn't handle being at home all the time and not. A lot of my self-worth I realize comes from my job. It's something I put a lot of time and effort into, and I've developed these skills over these years, and I don't want to lose it.
Yep.
But I've been fortunate enough that the group I work with is really, really understanding, and that they have been working with me to help me still be able to have both dreams of being a mom and taking care of my son, but also being a provider at the same time. So I
Yeah.
appreciate it.
That speaks to my heart so much. I love that too, because when my kids were little, we're kind of segueing a little bit on this video, but I think it's very relevant. It's something we never really talked about. But when my kids were little, I always struggled with this inner dialogue of, why is it that you don't want to stay home with the kids all the time? You're such a bad mom. Like, good moms want to stay home with their kids. They want to sit down on the floor and play Legos with their kids. And while I did want to do that, I didn't want to do that all the time. And I'm like you, I get a lot of my self worth from contributing more to the world than just the children that I raise. Not that that's not the most noble of all. I just don't have it in me to be that noble, you know.
Yeah.
So
Hard.
I think that is also the beauty of not pursuing the medical degree. And while there are plenty of female physicians who are managing both family and work, I would find that very challenging.
Yeah, absolutely.
Personally. So our careers kind of allow us to flex
Yeah,
and be at home more for a little while, and then when they grow up, you can go back to work at full time, like I'm
absolutely.
doing now.
Yeah.
So it's a really good career for working moms.
I
Do
think
you
so.
find that there are like any limitations that you experience as a PA versus being an NP? What you see?
Yeah, I think not having the nursing background, being a PA, I've had to learn, I spent a lot of time learning things like if I'm placing an arterial line in an artery and the setup is not available, I had to spend a long time learning how to set up an A line just in
How to do it
case.
on your own.
Yeah, where you guys can do it with your
Yeah.
eyes closed. And I still
Sure.
stare at it sometimes of, let me do this, let me do that.
Sure.
And it's the things of medicine where they tell you the roles, like this is a nursing role, this is a PA role, this is a physician role, but they overlap all the time.
Yes, they do.
So there's
Yes,
no
they
way
do.
to just, if someone's crashing or if there's something happening, you can't just stand there and say, I'm not going to do it. It's
Yeah.
not my role. When the
Yeah.
patient needs it, you're going to jump in and try to do it. So I think
Yeah.
that's what's frustrating a lot of the
Mm.
times is not knowing those things, or basic things like if a medication is compatible with another,
Mm.
things of trying to think in the future that I think you guys
Right.
do a better job of, which is why I love having a mix of PAs and NPs, because it's really for my selfish benefit that I can just go to you guys and be like,
Yeah.
can you help me figure out how to do
Yeah,
this?
yeah. Sure. Okay. And so conversely, what do you see as a benefit to being a PA as opposed to being an NP?
So the biggest benefit, and I honestly tell everybody all the time, I wish that NP schools would address that, is the model of teaching. I think it's really beneficial to have a medical model because that's what your job is, right?
Mm.
You can have an NP and a PA all lined up, but if you don't have your IDs, I'm sorry, NP, PA, and MD lined up, and if nobody has their badges on, you're not going to know the difference of who's who because we all kind of act in the same roles.
Sure.
Yes, physicians are responsible, and at the end of the day, it's their license that's being challenged or at risk if something goes wrong, as opposed to ours, where we have some fault in the situation, but it typically falls back on them. I feel like we should all be trained the same way because we all have similar roles.
Yeah, I can see that.
So I wish, and then I wish even if they could do like an inpatient or outpatient versus outpatient general practice for you guys, as opposed to having specific family medicine, critical care, or whatever specialty it is, because I feel like there's so many good NPs or even nurses who are limited because they wanted to go to family because they eventually want to have a family in the future when they would be really good critical care NPs, and they just are thinking long term and they miss out on an opportunity because it's not transferable.
I also think too, if you've been a nurse who really only worked in one particular area and then you go to advance your practice, you're missing out on so many other aspects of phases in which a patient is sick. Not everybody is critical. There are plenty of people who are in the hospital who are not critical. There are plenty of people in specialty clinics that have a different set of needs, and you've sort of been exposed to that in ways that we haven't. In your experience, do you feel like the pay is similar for PA and NP?
It's pretty standard. I think everywhere you go, you're just an APP now, or advanced practice provider. You're not PA versus NP. And I'm trying to think of no, because like you said, it may be in an OR, but at the same time, you'll just be a surgical APP. You're not going to be a surgical PA.
Yeah. I was going to say the same thing. Like we across the boards, everybody's pretty much paid the same. We function in the same way. OR is a little bit different, but you would also probably be paid on like call pay and how much time you're spending overtime too. So some of that is probably more of a factor than whether or not you have the PA degree or the NP degree. So okay, I want to talk a little bit about the job market. Do you think that the job market is the same for PAs and NPs, or is it better for PAs?
So 5 years ago, I would have said PAs are better. Mm-hmm. I think it's pretty much leveled out now.
Yeah.
I will say though, it depends on different experiences, different facilities. There's one of the hospitals I'm familiar with that now does not allow online NP graduates to take inpatient jobs because they've had issues in the past where maybe they weren't as well-rounded or as well educated on topics that they assumed they would have been if they went to a brick and mortar school.
Gotcha. Yeah, that makes sense. Yeah, so I could see that. Anything else relevant that you want to share or feel like the people need to know?
No. If I could give some advice, I think I would, whether you're doing NP or PA, try and shadow and set up different rotations in different areas if you can. Obviously, you're going to be comfortable with what you know, but it might not be what you enjoy the most in life. It's going to be the easiest, but I feel that if I would have stuck to to the ER, for example, and just kept working in tunnel vision myself to just the ER, I never would have ended up in critical care.
Yeah.
So I would say try and branch out as much as you can. The other thing I would say is every rotation you have, every encounter you have, whether it's with a tech or a custodian or a nurse or a physician, is always going to be a networking opportunity. So Absolutely. Don't shoot yourself in the foot by having a bad day and accidentally saying something you shouldn't say to somebody, because the medical field is a very, very small world.
That it is. You'll encounter the same people over and over again.
Yep. And so, for example, I trained in Michigan. That's where I worked. I came to Georgia because my husband's a resident here. And a couple of the attendings that work at the ICU here know people in Michigan and know my old attendings in Michigan. One of them knows one of the hospitals from my job from 4 years ago, and another one knows one of the attendings that from the job I had just come from. So if you weren't on your best behavior, if you weren't a hard worker, if you weren't somebody who was relatively easy to get along with, I could have very easily missed this job.
Yeah. They would have called and gotten recommendations. It's true. It's a very small world. Very, very true. Okay, well, you have, I'm sure, heard all the sweet little sounds that little Omar is making in the background. Okay, we're done.
Give him his pacifier.
Thanks so much, Haneen, for coming and joining us.
Thank you.
Hey, everybody. I'm so glad. I was literally just pulling my pants up. Like, get my pants up there before we get going. I would agree.
And then... and then
do you find that there are any limitations that preferentially it takes like 3 takes to get going because I'm like this is what it's like to be on YouTube the other side, to be a star, man.